In the context of cardiology, explain the potential clinical impacts of misinterpreting the term ischemia and differentiate it from infarction. What documentation precautions should a clinical documentation specialist (CDS) take to avoid such errors? Answer: ischemia refers to a reduced blood supply to tissues, causing oxygen deprivation. This condition is often reversible if recognized and treated promptly. Infarction, however, refers to tissue death caused by a prolonged lack of blood flow, usually due to a blocked artery. Misinterpreting ischemia as infarction can have significant clinical consequences, such as the unnecessary administration of invasive treatments, e.g., thrombolytic therapy, potentially leading to adverse outcomes like bleeding complications or inappropriate clinical management strategies. On the other hand, underestimating ischemia can delay necessary interventions and result in patient deterioration. To avoid these errors, CDS professionals must cross-check terminology, always confirm the physician's intent by reviewing diagnostic test results, e.g., EKG, troponin levels, and medical imaging, standardize abbreviations, avoid the use of ambiguous or non-standard abbreviations to ensure consistency in documentation, e.g. use me for myocardial infarction. Clarify with the physician, query unclear or non-specific documentation, ensuring accuracy and clinical relevance. What are the critical components of documenting a comprehensive history of present illness (HPI)? How does a poorly documented HPI impact clinical decision-making? Answer: a comprehensive HPI must include onset, when the symptoms started, providing crucial context for evaluating the illness, location, where the symptoms are occurring, e.g., chest pain, abdominal discomfort, duration, how long the symptoms have lasted, aiding in determining whether the condition is acute or chronic, character, the nature of the symptoms, e.g., sharp, dull cramping, which helps narrow down possible diagnoses, the aggravating relieving factors, actions or conditions that worsen or improve symptoms, e.g., pain relief with rest for angina, associated sign symptoms, any other symptoms accompanying the primary complaint, like nausea, with chest pain indicating potential myocardial infarction. A poorly documented HPI can lead to diagnostic delays or errors. For example, missing critical information like the duration or aggravating factors could result in a misdiagnosis or inadequate treatment plan. Incomplete documentation can also affect coding, leading to underreporting or incorrect reimbursement. Clinical decision-making relies on the accurate and thorough history to guide appropriate interventions, so inadequate documentation may result in delayed care or unnecessary procedures. As per CMS guidelines, comprehensive and accurate HPI documentation is crucial for proper coding, diagnosis, and treatment. Dr. Patel is reviewing the history of Mr. Henderson, a 55-year-old patient presenting with chronic fatigue. During the interview, Mr. Henderson provides conflicting information about his alcohol consumption and denies significant medical history. However, his spouse later mentions a history of hypertension and excessive drinking. What steps should the clinical documentation specialist take to reconcile these discrepancies? Answer: in this case, the clinical documentation specialist (CDS) should first focus on ensuring accurate and complete documentation. Steps include: verify with multiple sources, cross-check the patient's past records, including lab results, physician notes, and any previous diagnoses or procedures to see if there is a history of hypertension or alcohol use that may have been overlooked or underreported by Mr. Henderson. Clarify with the physician. The CDS should alert Dr. Patel about the conflicting statements and recommend that the physician readdress the alcohol history and hypertension, particularly if they were undiagnosed or misreported. Document discrepancies. It's essential for the CDS to document the discrepancy between the patient's and the spouse's accounts. This helps in transparency and provides a record that can be referred back to if the issue arises in the future. Encourage updates. The CDS should suggest that Dr. Patel formally update Mr. Henderson's medical history to reflect the newly discovered hypertension and alcohol use, as these can affect future treatment decisions, including medication choices. Define the terms bradykinesia and echinacea in neurology. How would misdocumentation of these terms affect the patient's treatment plan and prognosis? Answer: in neurology, bradykinesia refers to slowness of movement, which is commonly associated with Parkinson's disease. It results in reduced spontaneity and amplitude of voluntary movement, making tasks such as walking or speaking difficult. Echinacea is the absence of movement, often a more severe manifestation of motor dysfunction in Parkinson's disease or other neurological conditions. It refers to a complete loss of voluntary movement, which could significantly impair the patient's ability to perform daily activities. Misdocumentation of these terms could result in a variety of clinical and therapeutic missteps. For example, mistaking bradykinesia for akinesia may lead to more aggressive interventions, such as incorrect adjustments to medication, e.g., high doses of levodopa or unnecessary surgical procedures. Additionally, misidentifying bradykinesia as a more severe condition, akinesia, could lead to an inappropriate prognosis, potentially resulting in a failure to provide the patient with proper mobility aids or therapy. To avoid this, the clinical documentation specialist should ensure that the physician accurately documents the patient's motor symptoms, including distinguishing between bradykinesia and akinesia based on physical examination findings and patient-reported outcomes. Relevant guidelines, neurological evaluation standards stress the need for accurate documentation of motor symptoms, as these significantly influence treatment decisions, especially in neurodegenerative diseases. Discuss the risks associated with using non-standardized abbreviations in clinical documentation, providing examples of how this could result in patient harm. Answer: using non-standardized abbreviations poses significant risks, as they can lead to misinterpretations and, consequently, medical errors. For example, international unit can be misread as the intravenous, leading to an intravenous administration of a medication meant to be administered in units, potentially resulting in dangerous overdoses. A once daily might be confused with KID, 4 times per day, leading to overmedication or adverse drug reactions, especially with potent medications like anticoagulants or pain relievers. These errors can lead to serious patient harm, including medication overdoses, delayed treatments, and complications from incorrect dosing. Legal ramifications could also arise, such as lawsuits for medical negligence or patient harm resulting from ambiguous documentation. The Joint Commission and CMS both recommend eliminating unsafe abbreviations to protect patient safety and ensure clarity in medical records. To mitigate these risks, CDS professionals must ensure that documentation adheres to institutional and national standards, eliminating or replacing any non-standard abbreviations with clear, widely accepted terms. What techniques can a CDS recommend to a physician for improving the accuracy of patient history elicitation? Answer: several techniques can be recommended to physicians to ensure an accurate and comprehensive patient history. Open-ended questions encourage patients to describe their symptoms in their own words. For example, instead of asking, "Do you have chest pain?" you ask, "Can you describe the pain you're experiencing?" This allows the physician to gather more detailed information, reducing the chance of missed symptoms. Reflective listening. This involves repeating what the patient says to confirm understanding. For example, you mentioned that the pain started after walking up the stairs. "Can you tell me more about that?" This helps clarify any ambiguities in the patient's account. Use of structured questionnaires. Structured forms or checklists can ensure that the physician covers all necessary aspects of the history, including smoking, family history, lifestyle, and occupation. Cultural sensitivity. Ensure that language barriers, cultural differences, and social contexts are respected. For example, the physician should be aware of the patient's cultural background when discussing sensitive topics like mental health or substance use. How should changes in a patient's social history, such as smoking cessation, be documented and updated over time? Answer: smoking cessation and other changes in social history must be documented accurately and updated regularly to reflect the patient's current lifestyle and risk factors. The CDS should ensure the following: date of change. Record the date when the patient ceased smoking or any changes in other behaviors, e.g., quitting alcohol, starting exercise. This helps in tracking the patient's progress and determining the effectiveness of interventions. Ongoing monitoring. Ensure regular follow-up visits to track the patient's success in maintaining smoking cessation. Document any relapses and provide the necessary support or resources to encourage cessation. Impact on clinical care. Smoking cessation can influence other aspects of care, such as reducing the risk of cardiovascular diseases, lung cancer, and improving post-surgical healing. Ensure this is reflected in the patient's medical record. The CDS should encourage physicians to query about lifestyle changes during every visit, especially for chronic disease management. The ICD-10 centimeter codes for smoking cessation and related conditions should be applied to reflect the patient's efforts to quit smoking and track their progress in health improvement. What are the documentation challenges when managing patients with complex comorbidities, and how can SCDS address these challenges? Answer: managing patients with complex comorbidities presents several documentation challenges, including conflicting medical conditions. Comorbidities like diabetes and hypertension may require conflicting treatment regimens, complicating documentation. The CDS should ensure that the medical record clearly differentiates between treatments for each condition and indicates any medication interactions or adjustments. Interdisciplinary care. Multiple specialists may be involved in a patient's care, requiring clear communication and documentation to ensure all aspects of the patient's health are addressed. Comprehensive assessment. Ensuring that the medical record includes comprehensive assessments of all relevant comorbidities is vital. The CDS should recommend standardized templates or checklists for physicians to ensure they document all conditions, including severity, progression, and treatments. To address these challenges, the CDS should collaborate with the clinical team to standardize documentation practices and recommend protocols that account for the intricacies of managing multiple conditions. What is the importance of accurate height 10 cm coding in clinical documentation, and how does it impact reimbursement and patient care? Answer: accurate height 10 cm coding is critical for several reasons. Reimbursement. Insurance companies use height 10 codes to determine the level of reimbursement for services. Incorrect coding can lead to underpayment, overpayment, or claim denials, which affects the financial health of the institution and provider. Patient care. height 10 codes help track a patient's health status, ensuring that appropriate care is provided based on accurate diagnosis. Misidentifying conditions may result in inadequate treatment, delaying recovery, or exacerbating the illness. Data reporting. Accurate coding contributes to healthcare quality assessments and public health surveillance, providing a detailed view of health trends and outcomes, which can inform future healthcare policies and research. The CDS plays an essential role in ensuring that the codes are accurate and specific, reflecting the full scope of the patient's diagnosis and treatments. This helps in both clinical decision-making and ensuring the institution's financial stability by improving the accuracy of reimbursement. Discuss the legal and ethical considerations for clinical documentation specialists in ensuring accurate patient records. Answer: legal and ethical considerations include accuracy and integrity. CDS professionals must ensure that documentation accurately reflects the patient's condition and treatment plan. Falsifying or altering records could lead to legal consequences, such as malpractice suits. Confidentiality. Adherence to HIPAA and other privacy regulations is paramount. CDS professionals must ensure that patient information is securely stored, with access limited to authorized individuals. Ethical practice. CDS professionals should uphold ethical standards by maintaining transparency in documentation, ensuring the completeness and accuracy of the medical record. Any discrepancies should be reported and appropriate clarifications sought from the physician. Following a HEMA's Code of Ethics and HIPAA guidelines ensures that the CDS meets both legal and ethical obligations, contributing to the overall quality of care and legal compliance. What are the main characteristics of high-quality clinical documentation, and why is each characteristic essential in the clinical setting? Answer: high-quality clinical documentation is critical in ensuring patient safety, accurate reimbursement, and legal protection. The key characteristics are accuracy. Documentation must reflect the true nature of the patient's condition, treatment, and progress. Inaccurate documentation can lead to incorrect treatment, billing errors, and legal complications. Clarity. The information should be clear and understandable to all healthcare providers, avoiding ambiguity that could lead to misinterpretation. Brevity. While completeness is necessary, concise documentation is essential. Overly detailed or redundant entries may obscure critical information and slow down the care process. Timeliness. Documentation should be completed promptly, as delayed documentation can affect patient care, continuity of care, and compliance with regulatory timelines. Each of these characteristics ensures the proper communication of the patient's health status, compliance with regulatory standards, such as HIPAA, and a legal record that may be necessary in case of litigation. Timely and accurate documentation supports both clinical decision-making and financial reimbursement, adhering to CMS guidelines. Why is the use of electronic health records (EHR) beneficial in terms of ensuring compliance with regulatory standards, and what are some challenges that still exist? Answer: HRS provides several benefits that help ensure compliance with regulatory standards. Improved accuracy. HRS reduce errors related to illegible handwriting and transcription mistakes, ensuring that documentation is both complete and accurate. Efficiency in documentation. With standardized templates, HRS streamlined the documentation process, ensuring that the right information is captured in a consistent format, which supports adherence to guidelines from organizations such as the Joint Commission and CMS. Audit trails. HRS automatically track changes made to patient records, ensuring that all modifications are traceable. This is crucial for compliance with regulations such as HIPAA, which requires that all health information be secure and that any changes to records are auditable. However, challenges remain. User training. Properly training staff on how to use EHRS effectively is essential. Poorly trained staff may input incorrect data or fail to complete necessary documentation. Interoperability issues. Not all EHR systems can communicate with one another, potentially leading to fragmented patient data, which can impair coordination of care and documentation accuracy. Data security. While EHRS enhance security in many ways, they are also susceptible to cyber attacks which can compromise patient data. HIPAA mandates stringent safeguards to protect electronic health information. Dr. Sero is reviewing her clinical notes and realizes she has not documented a critical change in a patient's condition that occurred during the morning rounds. She is concerned about the legal implications and whether this will affect the reimbursement process. What steps should Dr. Sero take to address this issue, and what are the consequences of failing to amend the documentation? Answer: Dr. Sero should take the following steps. Amend the documentation. Dr. Sero should immediately correct the clinical record by adding the missing information, ensuring that the update is accurate, clear, and documented in the correct section of the EHR. Document the amendment. Dr. Sero should include a note explaining why the change was made. Timeliness. Dr. Sero should make the amendment promptly to ensure that the documentation reflects the current state of the patient's condition, especially in cases where it impacts the care plan. Failure to amend the documentation can lead to several consequences. Legal implications. Incomplete or inaccurate documentation may affect the ability to defend against malpractice claims or regulatory investigations. Reimbursement issues. CMS and other insurers require accurate and complete documentation to justify reimbursement. Quality of care. If the change in the patient's condition is not documented, it could lead to miscommunication among the healthcare team, potentially affecting patient care. What are the core components of HIPAA and how do they impact clinical documentation practices? Answer: HIPAA, Health Insurance Portability and Accountability Act, is a critical regulation in healthcare that ensures the privacy and security of patient information. The core components that impact clinical documentation are: Privacy Rule. This rule establishes standards for the protection of patients' medical records and other health information. Clinical documentation must be handled in a way that ensures patient confidentiality, with access limited to authorized individuals. Security Rule. This rule sets standards for safeguarding electronic protected health information, (FI). Clinical documentation must be stored and transmitted securely using encryption and other safeguards to prevent unauthorized access. Breach Notification Rule. If a healthcare organization experiences a breach of patient data, it must notify affected patients and the Department of Health and Human Service (HHS) within a specified time frame. Inaccurate or incomplete documentation can increase the likelihood of such breaches, as improperly secured data is more vulnerable. For clinical documentation specialists, understanding HIPAA is essential to ensuring compliance with data protection standards and preventing legal or financial penalties related to privacy violations. How can the proper use of SOAP notes improve the quality and compliance of clinical documentation, and what is the potential consequence of not adhering to the SOAP format? Answer: the SOAP Subjective Objective Assessment Plan format is a structured way of documenting patient encounters. It ensures that all relevant information is recorded in an organized manner. Subjective includes the patient's own report of symptoms, concerns, and medical history. Objective documents measurable or observable data such as vital signs, lab results, and physical examination findings. Assessment: the clinician's diagnosis or interpretation of the patient's condition based on subjective and objective information. Plan: the treatment plan or recommendations for further investigation or care. Benefits: improved documentation. SOAP notes ensure that all relevant information is captured in a logical sequence, which is vital for continuity of care. Compliance with guidelines. Adhering to this format helps meet the documentation standards of CMS, the Joint Commission, and other regulatory bodies. Consequences of not following the SOAP format. Incomplete documentation. Critical elements of patient care may be missed, leading to confusion or miscommunication among healthcare providers. Reimbursement issues. Incomplete or poorly structured documentation can result in claim denials or reduced reimbursement. Legal risk. In the event of an audit or lawsuit, poor documentation can be used to demonstrate negligence or inadequate care. In what ways does CMS, Centers for Medicare and Medicaid Services, regulate clinical documentation, and what are the potential penalties for non-compliance with these regulations? Answer: CMS regulates clinical documentation primarily through its conditions of participation, COPS, which outline the standards healthcare facilities must meet to participate in Medicare and Medicaid programs. CMS requires that clinical documentation reflect the true nature of the patient's condition. It should provide accurate, up-to-date, and thorough information about the patient's diagnosis and care plan, supports medical necessity. Documentation must justify the need for the care provided, which is essential for reimbursement under Medicare and Medicaid. Penalties for non-compliance include claim denials or reductions. If documentation does not meet CMS standards, claims may be denied or payments may be reduced. Penalties and fines. Healthcare organizations may face penalties for non-compliance with documentation standards or billing inaccuracies, especially under the False Claims Act. Exclusion from CMS programs. In severe cases, non-compliance may result in exclusion from Medicare and Medicaid programs, which could be financially devastating for healthcare providers. What role does the Joint Commission play in clinical documentation, and what other standards healthcare organizations must meet to maintain accreditation? Answer: the Joint Commission (EJC) is a key accreditation body that evaluates healthcare organizations to ensure they meet certain quality and safety standards, including those related to clinical documentation. TJC requires that documentation accurately reflects the care provided. Documentation must be complete and precise to support the diagnosis, treatment, and patient outcomes. Meets legal and regulatory standards. Clinical records must comply with state and federal regulations, including HIPAA, and should be accessible for review during audits. Organizations must regularly review their documentation practices to ensure compliance with these standards, as TJC evaluates documentation as part of the overall accreditation process. Mr. Harris, a physician, has recently started documenting his patient encounters using shorthand and abbreviations to speed up his charting. He believes it helps him work more efficiently, but is concerned about potential errors. What should Mr. Harris consider regarding documentation standards, and how might his approach impact legal and regulatory compliance? Answer: Mr. Harris should be aware that clarity and legibility. Shorthand and abbreviations may lead to misunderstandings, especially if they are not universally recognized. Inaccurate documentation due to unclear abbreviations could result in patient safety risks. Regulatory compliance. The Joint Commission and CMS both emphasize that documentation must be clear and unambiguous. Abbreviations that are not universally accepted can lead to compliance issues, particularly in audits. Legal implications. In the case of a legal dispute, unclear documentation could be scrutinized and it may be used to show negligence or inadequate care. Mr. Harris should use standardized documentation practices to ensure clarity and compliance with regulations. What are the primary goals of effective clinical documentation, and how do these goals impact patient care, legal compliance, and reimbursement? Answer: effective clinical documentation serves several critical goals: supporting continuity of care. Clear and comprehensive documentation ensures that all healthcare providers have access to the patient's complete medical history and care plan. Providing a legal record. Documentation serves as a legal record of the care provided, which can be crucial in defending against malpractice claims or audits. Enhancing communication. Effective documentation improves communication among the care team, which enhances decision-making and patient outcomes. Ensuring accurate reimbursement. Proper documentation is essential for billing, as it justifies the medical necessity of the services provided, supporting reimbursement from insurers, including CMS. What are the most common risks of inadequate clinical documentation, and how can clinical documentation specialists mitigate these risks? Answer: common risks of inadequate documentation include medical errors. Incomplete or inaccurate documentation can lead to misdiagnosis, inappropriate treatment plans, and compromised patient safety. Financial consequences. Insufficient documentation can result in claim denials or reduced reimbursement, especially from CMS. Legal liabilities. Poor documentation can weaken a healthcare organization's defense in lawsuits or malpractice claims. To mitigate these risks, clinical documentation specialists can provide training, ensuring that all healthcare providers are well trained in accurate documentation practices. Conduct regular audits, regularly reviewing documentation to identify errors or inconsistencies and correct them before they affect patient care or reimbursement. Implement standardized templates. Using standardized documentation templates can improve the consistency and completeness of clinical records. Scenario: Dr. Patel has documented in a patient's record that they underwent a left knee arthroscopy for meniscal tear. The coder has linked this procedure to the ICE 10 cm code for unspecified injury of knee and the CPT code for diagnostic knee arthroscopy. However, during the billing review, discrepancies in reimbursement arise. Question: what errors might exist in the coding, and how should the documentation and coding be corrected to ensure compliance and accurate reimbursement? Answer: in this scenario, there are two primary issues: the incorrect ICE 10 cm diagnosis code and the inaccurate CPT procedure code. The ICE 10 cm code of unspecified injury of knee, e.g., 0.900 nini, is too vague for a meniscal tear diagnosis and doesn't provide sufficient detail regarding the type of tear or the laterality of the knee involved. The correct diagnosis code should specifically identify the meniscal tear and its location, for instance, 0.242a for a left knee medial meniscus tear, current injury, initial encounter. Additionally, the CPT code for a diagnostic knee arthroscopy, e.g. 29870, doesn't capture the full scope of the procedure if a meniscectomy, removal of damaged meniscus tissue, or meniscus repair was also performed. The appropriate CPT code should reflect this, such as 29881 for arthroscopy with meniscectomy. To correct these errors, the documentation should be reviewed and updated with more precise descriptions, ensuring laterality and the procedure's therapeutic nature are captured. The ICE 10 cm official guidelines for coding and reporting emphasize the importance of specificity in diagnosis coding, and CPT Assistant provides clarification on distinguishing diagnostic from therapeutic arthroscopies. Why is it essential to link diagnoses to procedures accurately, and what are the potential consequences of failing to do so? Answer: accurately linking diagnoses to procedures is crucial for several reasons, primarily to demonstrate medical necessity and ensure appropriate reimbursement. In the context of clinical documentation and coding, each procedure of EECS must be supported by a corresponding diagnosis code, ICE 10 cm, to justify the need for the treatment. This linkage helps establish the rationale for performing a procedure which payers, especially Medicare and private insurers, require to reimburse healthcare providers. If there's a mismatch or incorrect linkage, it can result in claims being denied or paid at a low rate. Furthermore, improper coding can attract audits from government bodies like the Office of Inspector General, OIG, potentially leading to investigations under the False Claims Act (FCA). These audits could reveal intentional or unintentional fraud, resulting in penalties, fines, or even criminal charges for the healthcare provider. Moreover, mislinked codes can impact hospital performance metrics like diagnosis-related group ERGS, affecting the overall reimbursement and potentially lowering the hospital's revenue. To mitigate these risks, coders must stay up to date with coding guidelines and work closely with clinical teams to ensure that documentation accurately reflects the services provided. A coder assigns the DRG for a patient diagnosed with acute myocardial infarction (AMI) as DRG 280. Upon review, you notice the patient's stay included complications like cardiogenic shock and respiratory failure. Evaluate the coding and DRG assignment. Answer: the DRG assignment for this case is incorrect. DRG 280 refers to patients with acute myocardial infarction (AMI) who are discharged alive without any major comorbidities or complications (CC) or major comorbidities or complications (MCC). However, the patient in this scenario has additional complications such as cardiogenic shock and respiratory failure, which are major complications that should have been considered when assigning the DRG. To correct this, the coder should assign a DRG that reflects the increased severity of the patient's condition, such as DRG 286 for acute myocardial infarction, discharged alive with ME. This DRG accounts for the additional complications, which significantly impact the patient's care and resource utilization. The ICE 10 cm official guidelines require coders to capture all significant diagnoses that influence the patient's care and treatment, including complications like cardiogenic shock (J.0) and respiratory failure (J.0), which, when properly documented, would trigger the MCC designation. These complications can also impact reimbursement, as more severe conditions require additional resources, length of stay, and care. Accurate DRG assignment is vital for reimbursement optimization and reflecting the true cost of care. Explain the significance of transitioning to ICE 11 for clinical documentation and coding practices. Answer: the transition from ICE 10 to ICE 11 marks a significant shift in clinical documentation and coding practices, offering several advantages for healthcare providers, researchers, and payers. One of the primary benefits of ICE 11 is its increased specificity and accuracy. With over 55,000 codes, ICD-11 provides a more granular classification of diseases and conditions, which enhances the ability to capture clinical data more effectively. This specificity enables better tracking of disease prevalence, treatment outcomes, and health trends across different regions and populations. Moreover, ICD-11 aligns with global healthcare standards, facilitating international comparisons and health research. It supports clinical interoperability, enabling health data to flow seamlessly between countries, which is crucial for public health efforts and disease surveillance. For clinical documentation, the adoption of ICD-11 means the coders must be well versed in its structure and application, requiring comprehensive training and updated documentation practices. It will also lead to changes in payer requirements, with insurers and government health programs adjusting their systems to accommodate the new code sets. However, transitioning to ICD-11 presents challenges, including the need for updated electronic health record systems and coded training programs to ensure accurate coding. This transition is being phased in globally, with different regions adopting the system based on their healthcare infrastructure. The World Health Organization, who sets the timeline, but each country may have varying implementation dates. Scenario: MS. Carter, a patient with diabetes, presents with a foot ulcer documented as infected involving the metatarsal area with gangrene. The coder applies a non-specific code for a diabetic foot ulcer. However, the hospital's billing team raises concerns about insufficient reimbursement. Question: what should the coder do to rectify this, ensuring accurate DRG assignment and reimbursement? Answer: the coder in this case needs to revise both the diagnosis coding and the DRG assignment to ensure the correct level of reimbursement. The initial coding of a diabetic foot ulcer is too broad and does not capture the severity of the condition. Since the documentation specifies that the ulcer is infected, involves the metatarsal area, and has gangrene, the coder should apply more specific ICD-10 codes. The most appropriate codes might include E.621 type 2 diabetes mellitus with foot ulcer and L.523 non-pressure chronic ulcer of other part of left foot with necrosis of muscle. The involvement of gangrene necrosis is a serious complication and should be coded accordingly to reflect the severity of the ulcer. Failure to capture the full complexity of the condition can result in underpayment because DRG assignment is based on the comorbidities and complications present, which impact the severity of illness and length of stay. For DRG assignment, this case likely falls under DRG 573, skin ulcer with MCC, reflecting the serious nature of the infection and the presence of gangrene. By capturing the severity of the condition, the coder ensures that the facility is appropriately reimbursed and compliant with Medicare Severity Diagnosis Related GRU/MORG guidelines. Proper documentation is critical to accurately reflect the care provided and optimize reimbursement. How does an understanding of the cardiovascular system enhance the documentation of heart disease in medical records? Answer: an understanding of the cardiovascular system is essential for accurately documenting heart disease because it allows coders to capture critical details that influence diagnosis coding and DRG assignment. The cardiovascular system includes the heart, blood vessels, and blood circulation, all of which are involved in various cardiovascular conditions such as myocardial infarction, heart failure, arrhythmias, and peripheral artery disease. For example, when documenting myocardial infarction, the coder must distinguish between the type of MI, G, NSTE, MI STEMI, and the specific location of the infarction, G, anterior wall, inferior wall. Additionally, understanding terms like ejection fraction, F in heart failure cases helps coders properly document the severity of heart failure, which impacts severity of illness measures and DRG assignment. LOE, F may indicate severe heart failure and affect resource utilization. Moreover, cardiovascular conditions often come with complications like arrhythmias, e.g., atrial fibrillation or cardiogenic shock. Coders must capture these associated diagnoses to accurately reflect the patient's condition. An understanding of the pathophysiology and clinical presentations of heart disease enables coders to ensure complete and precise documentation, minimizing the risk of claim denials and ensuring that patients receive appropriate treatment. What are the primary differences between ICD-10 and ICD-11, and why is the transition to ICD-11 important for health organizations? Answer: the primary differences between ICD-10 and ICD-11 lie in their structure, coding complexity, and the level of detail each offers. While ICD-10 provides over 14,000 codes, ICD-11 increases this number substantially to over 55,000 codes, offering much more specificity in terms of disease classification and diagnosis details. ICD-11 is also structured to align better with modern healthcare practices, including the use of electronic health records (EHRs), and supports the global exchange of health data through its compatibility with digital platforms and health information systems. Unlike ICD-10, which uses a numeric system for codes, ICD-11 employs a hierarchical structure that makes it easier to navigate and find relevant codes. The transition to ICD-11 is important for health organizations because it enhances the precision of diagnosis, supporting more accurate data for research, epidemiology, and health policy decisions. It also supports clinical interoperability, enabling health systems worldwide to use a common coding standard for diseases, thereby improving the accuracy of health data exchanges across borders. For health organizations, transitioning to ICD-11 is crucial for improving data quality, enhancing patient care, and ensuring reimbursement accuracy. Explain the concept of medical necessity in coding and how it affects the reimbursement process. Answer: medical necessity is a fundamental concept in healthcare coding that determines whether a particular service or procedure is appropriate, justified, and covered by insurance. It refers to services that are consistent with the patient's diagnosis, clinically appropriate, and supported by scientific evidence as necessary for diagnosing or treating a patient's condition. In the coding process, medical necessity ensures that the procedure or service is needed based on the patient's clinical condition. Inaccurate coding that fails to demonstrate medical necessity can lead to claim denials or underpayment. Insurance companies, including Medicare, require that all billed services and procedures be substantiated by a corresponding ICD-10 centimeter diagnosis that justifies the treatment. Without proper linkage between diagnoses and procedures, payers may refuse to reimburse the facility or provider. For instance, a procedure performed for a non-medical reason, such as a purely cosmetic surgery, would not be covered under the insurance policy unless justified as necessary for medical reasons, e.g., reconstructive surgery following an injury. Coders must ensure that the documentation supports the medical necessity of services to avoid audits and ensure full reimbursement. In the context of ICD-10 centimeter coding, explain the role of laterality and how it affects code selection. Provide examples of conditions where laterality is particularly important. Answer: laterality refers to the specification of which side of the body is affected by a condition, and it plays a critical role in the accuracy of ICD-10 centimeter code selection. Many medical conditions are site-specific, meaning they affect the left or right side of the body differently. Proper documentation of laterality ensures the correct code is chosen, leading to accurate diagnosis, representation, and correct billing. For example, in the case of osteoarthritis of the knee, ICD-10 centimeter provides separate codes for the left knee mm.12 for left knee osteoarthritis and the right knee mm.11 for right knee osteoarthritis. This distinction is necessary because the treatment and care for each side might differ, and knowing which side is affected allows healthcare providers and insurers to assess and treat the condition properly. Similarly, conditions like rotator cuff injuries and fractures of the femur also require specification of laterality. For instance, S.401A is used for the fracture of the right humerus and S.402 is for the left. Inaccurate or missing laterality can lead to coding errors, claims denials, or underpayment. It's important for coders to verify that the healthcare provider documents laterality in the patient's record, especially for conditions like hernias, stroke, hemiplegia, and cancer, where site-specific diagnosis is essential. What is the importance of accurate documentation for complications and comorbidities in clinical coding, and how does it affect reimbursement? Answer: accurate documentation of complications and comorbidities is essential in clinical coding because it significantly impacts the severity of illness, SOI, and risk of mortality, ROM scores, which in turn influence DRG assignments and reimbursement rates. Complications and comorbidities are conditions that exist alongside the primary diagnosis and either affect the patient's recovery or increase the resources needed for treatment. Properly documenting these conditions ensures that the coding reflects the true complexity of the patient's condition and the level of care required. For example, a diabetic patient with a foot ulcer that becomes infected and leads to gangrene would have a much more complicated case than a simple diabetic foot ulcer. The correct coding should include the presence of infection, gangrene, and any associated comorbidities, which will result in a high-weighted DRG, indicating a more resource-intensive treatment plan. If the comorbid conditions are not documented, the hospital might be assigned a lower DRG and receive reduced reimbursement. Complications and comorbidities can also affect the length of stay, loss, and the intensity of care required. For instance, respiratory failure in a patient with pneumonia would need additional interventions, such as mechanical ventilation, which directly influences the care process. If these conditions are not captured, the reimbursement could be insufficient to cover the actual cost of treatment. Accurate documentation also helps prevent claim denials or audits by demonstrating that the medically necessary treatments align with the documented complications or comorbidities. It is crucial for coders to work closely with healthcare providers to ensure that all relevant complications and comorbidities are well documented and properly coded to reflect the true severity of the patient's condition.